and our opioid technical assistance team. I am Mark Duncan, one of the regular trainers here, an addiction psychiatrist at the University of Washington. Work with mostly prescribers, and I'll be facilitating this session this afternoon on June 2nd, 2025. So let's get to the next slide. Okay, a few housekeeping things before we get started. This call is being recorded. We do try to make these available as soon as we can, but there's always somewhat of a delay. While speaking, when that time happens, please keep yourself on mute, or it's okay to unmute yourself, but if before then, please keep yourself on mute. We'll be getting to all of the questions at the end of the session today. If there are questions that come up during the presentation, feel free to please chat those in or type those into the chat. They'll kind of serve as good placeholders, and we'll get to as many of those questions as possible at the end. And you can hopefully everyone's familiar with the audio and video controls in the corner of your devices or computers or whatever you're viewing this on. Next slide. And just like to start off by acknowledging that as we gather today, we are on the ancestral homelands of the indigenous peoples who have lived on these lands since time immemorial. Please join me in expressing our deepest respect and gratitude for our indigenous neighbors. Okay, and our next slide. So as I mentioned, this is the first of a three-part series on methamphetamine use and various health concerns. This one today is going to be focusing on mental health concerns in particular. And then on June 9th, we'll be getting into the effects of meth on wound care and skin health. And on June 16th, we'll be talking about cardiovascular care in relation to someone's meth use. So hopefully you'll be able to join us for all three of those. These are all kind of issues that come up when you're working with someone who is using meth and should be very helpful in your practice. Next slide. Okay. So with that, I'd like to kind of kick things off and introduce our speaker for today. So we're fortunate enough to have Kayla Cross. Kayla is a certified psychiatric nurse practitioner, mental health nurse practitioner who specializes in mental health and substance use issues. She treats a full spectrum of children, adolescents, and adults, and clinically works at the Spokane VA in private practice in Spokane, and then also at the Compassion Addiction Treatment. She is on the clinical faculty at Gonzaga and has put together a really nice practical presentation here on addressing mental health problems in people using methamphetamine. So, Kayla, I will turn things over to you to fill out your bio if you need to, and then get into your talk. So thank you for doing this today. Really appreciate it.
Wonderful. Thank you. Hello, everybody. Welcome. Thanks for showing up today and kind of tuning in to see how we work with people using methamphetamine and with kind of co-occurring mental health issues. So as I said, I'm Kayla. I'm in Spokane. Kind of work around some different areas, but primarily work with a lot of co-occurring disorders with substance use and mental health issues. Getting used to the slide. So I have no financial disclosures to report, no conflicts of interest, no relationships with pharmaceutical or industry companies, and we will hop right into things. All right, so just kind of quickly our learning objectives for today. You can kind of read over these, but some things we're going to go over is your ability to describe 2 acute effects of methamphetamine use, common mental health issues related to methamphetamine use, any suicide risk related to methamphetamine use, and then treatment options, primarily around some of the mental health symptoms that often go along with methamphetamine use. Okay, so we'll just kind of start out with kind of the basics about methamphetamine. So in general, people will usually take methamphetamine by snorting it, injecting it, or smoking it. You can take it orally, but it is not absorbed as quickly or as well by that route, so that is less utilized. The effects of methamphetamine use last up to 24 hours, but it has kind of like a longer time that it stays in your system and that you feel those effects, usually around 12 hours. We know that crystal methamphetamine is more pure, more concentrated than powder methamphetamine. And we also know from testing different methamphetamine over the years that it is more and more pure from what people are using. For example, in 2007, it was around 37%, and 2019, 97%. So people, as they're using methamphetamine and as this problem has been kind of growing over the years, are getting more and more out of the substance that they're using, which may have something to do with a lot of the side effects people are experiencing from ongoing use. So as part of that, we're also seeing a lot more hospitalizations, a lot of times for psychiatric reasons, both with methamphetamine intoxication and sometimes just post-methamphetamine use when there's these ongoing symptoms that aren't going away and that are negatively impacting the person. And we'll talk a little bit more about that as we go through this. So we've seen a lot more and more of that with positive methamphetamine results on tox screens at admissions. And then we also know, just kind of for comparative sake, paranoia from methamphetamine use can last as long as like 7 to 14 days. So those effects can be there well after the methamphetamine has kind of cleared the system, which is a lot different than cocaine, for instance, where a lot of times if there's any kind of paranoia, that's gone within like 4 to 8 hours. So with methamphetamine, we're seeing these effects much longer, both during an episode of use and sometimes after. We also know that just kind of collectively, methamphetamine is very easy for people to get a hold of. Similar to like the comparison of fentanyl and heroin, like, you know, fentanyl is easy to manufacture and then distribute, and it can be made in bulk, similar with methamphetamine. So it is manufactured, very easy to get mass amounts of it and then to distribute to people. More potency, and then it has the higher addiction potential related to that. And what does methamphetamine do kind of in your brain? Well, the biggest thing it does is release, kind of flood your brain with dopamine. So this slide is just kind of an example of how different substances affect dopamine levels in the brain. And if you can see on that y-axis, the up and down axis, your number points are different. So these look like they might be similar, but if you look at the methamphetamine, which is the lower right hand side, that release of dopamine is at 1500, and the other ones, you know, are 250 for alcohol, 250 for nicotine, around 400 for cocaine. So this is well above 3-4 times as much of a dopamine flooding in the brain than even like cocaine, for example. So this study was done in rats with how dopamine was released with these different substances. But this is what we kind of see, and this is part of what reinforces that ongoing use, because there's that huge flood of dopamine, which feels good, creates that euphoria, and it also kind of hijacks your brain as far as like what to prioritize and what is important for life, right? Because we get little dopamine jumps with eating and sex and different substances, but the things that kind of reinforce you need to keep doing them to stay alive, that's part of what dopamine does in the brain. But methamphetamine just kind of hijacks that whole system and floods the whole brain with a whole bunch of dopamine, which then makes it really hard to regulate, especially in response to other things that are a lot lower dopamine levels. And then we don't, as far as we're aware of at least, there isn't really anything else that exists in nature that has such a significant and large impact on dopamine levels outside of methamphetamine. So what kind of things do we see as far as mental health and methamphetamine use? So for kind of the immediate effects, we see that kind of fight or flight response in the brain and the body, where your heart rate goes up, your blood pressure goes up, vasoconstriction, which means like your blood vessels kind of pull in, your lungs kind of are able to breathe a lot more, that bronchodilation. Sometimes your blood sugars go up because your body is getting ready to like respond to something, fight or flight or whatever. But you're in this kind of hyper alert, hyper vigilant mode. As far as your central nervous system, you're feeling kind of euphoria, a lot more energy, more alert, kind of that hypervigilance, maybe really curious, interested in a whole bunch of different things, less anxiety because you're focused in on whatever the potential threat is. That's part of that fight or flight. And then a lot of times kind of increased or enhanced self-esteem, sometimes feelings of grandiosity, like feeling a lot more important than you normally would. And just kind of that overall sense of like really elevated dopamine levels. As far as neurologic complications, we see sometimes stroke, which would be like a bleed that happens inside the brain. Seizures can happen, more behavioral kind of agitation, being super restless, irritable, sometimes hyperthermia, which means getting like really hot, like your body gets really, your body temperature gets really elevated, a lot of sweating, which is not good for your body, right, if that's not controlled. And then psychiatric complications, we'll see sometimes psychosis, and we'll go over some of these a little bit more in detail, but psychosis, paranoia, like worrying about kind of what things are going on around you and what that might mean towards you, feeling like you're under threat, some confusion sometimes, and even some cognitive dysfunction. So with kind of acute intoxication, like when a person is actively intoxicated with methamphetamines, there's things from a mental health perspective that we really want to make sure we're kind of checking for to promote safety of the person and you, maybe if you're in that situation around someone who's actively intoxicated with methamphetamine. So some of the acute considerations include risk of suicide or violence towards other people. Sometimes that has to do with that kind of agitation that we talked about, but sometimes it's part of reduced inhibitions with intoxication. So being sure that there's kind of a safe environment, no weapons around, just promoting things that are going to create a more safe space for everyone that's in that situation. Watching out for seizures or any kind of convulsions. If someone has any type of seizure, you want to lay them on their side, turn them to their side so that if they throw up, that they don't choke on the vomit. So we just want to make sure we're kind of paying attention for anything of that sort. Psychosis, again, with maybe mania, feeling kind of really on top of the world, grandiose, really impulsive, not really always thinking through consequences, feeling just kind of untouchable. Delusions, meaning thinking things that are happening that other people are not thinking are happening or are not experiencing the same thing. Hallucinations, so seeing things that other people aren't seeing, hearing things other people are not hearing, sometimes feeling like tactile hallucinations, and that paranoia. Agitation, aggressiveness kind of goes hand in hand with just kind of watching for any kind of risk of violence. And then panic attacks or really extreme anxiety, which oftentimes goes with that really elevated fight or flight feeling that your body's getting ready for some kind of situation. And then what do you do with all that kind of intensity and feeling? So a lot of the kind of interventions that we use with any kind of active intoxication, a lot of kind of de-escalation. So not trying to confront people or tell them, either to stop using or confronting whatever's going on with them, but more just talking to them and trying to de-escalate the situation, help with kind of trying to calm the situation because it may be hard to know what they're experiencing, if they are having any kind of like hallucinations, paranoia, delusions. You may not be aware of different feelings of threat they might be having. Sometimes at this point, they might present to a hospital or might be brought to a hospital by somebody else. With acute intoxication, sometimes we can give them medications that help pull down that fight or flight response. Or if they have their own medications that, are used to treat any of that, if they've had kind of ongoing symptoms of this, if they have as needed or other medications that they're prescribed and they're willing to take them, might be a good time to do that. Really, the best response for any kind of like methamphetamine intoxication or like maybe an overdose is to just kind of be paying attention to what's going on with that person, because you really want to respond appropriately just to the situation, and offering and trying to create that safe space, making sure they have like water, fluids, in case they are having that hypothermia with the increased body temperature. Trying to minimize stimulation sometimes helps. So turning off lights, having it less noisy, less chaotic, and just trying to create less chaos in that space. Okay. And outside of like an acute intoxication or that kind of elevated brain and body response, we also see some things more chronically with people who use methamphetamine. So methamphetamine, especially ongoing methamphetamine use, can cause neurotoxicity, meaning that it damages kind of different parts of how your brain works. It could damage some of the neurotransmitter pathways like dopamine, serotonin, norepinephrine. These are some of the neurotransmitters in your brain that kind of how your brain cells talk to each other and let you know like you're feeling good or things are going okay, or this is a like scary situation and you need to be prepared for some kind of quick response. So all these little neurotransmitters play a part in your brain to help you respond to what's going on in your environment and what you're experiencing. And ongoing methamphetamine use can really negatively impact how those neurotransmitters are able to talk to each other, and how you're like at the cellular level, they get sent and caught to each other so that you can have a fairly stable mood, not have a whole bunch of anxiety, respond to situations appropriately, recognize situations appropriately. So we do know that that can be damaged, sometimes irreversibly. A lot of times we see a lot of improvement with people once they stop using methamphetamine, but other times there are some really lasting impacts that can kind of endure for years and years and years. Ongoing methamphetamine use can also result in brain damage to the hippocampus, which is part of your memory center in your brain that helps with connecting memories to events, and recognizing and remembering things accurately at various times. And also your prefrontal cortex, that's kind of the front area of your brain, and that is like your executive functioning section. So like prioritizing things, planning ahead, problem solving, especially like multiple step problems and tasks. And that section is also, that part of your brain is also really important for setting goals and like being able to wait and set kind of longer term goals instead of just having immediate gratification type goals. Let's see. We also know that with like methamphetamine use, these kind of effects in your brain are substantially worse with methamphetamine than they are even with like cocaine, or even prescribed stimulants are very different than methamphetamine use. We know the higher the dose or amount and frequency of use, the more risk there is for having some of this damage to the different neurotransmitter pathways, and damage to that memory center and prefrontal cortex. A lot of times with that ongoing damage that's kind of happening incrementally over time, then we can see when people try to stop methamphetamine use, they have a lot more depression. They just feel like nothing really matters. And again, if you kind of think back to the beginning when we had those really high spikes in dopamine, if you're having that regularly from like regular methamphetamine use, and that's what's given your brain that, okay, this is an okay situation, there's nothing else that you're going to experience that's going to come close to that feeling. So everything kind of feels flat after either stopping methamphetamine use or trying to stop and just feeling like really kind of like a lack of interest in anything. Hard to feel joy or pleasure from anything because nothing, again, you're going to have little dopamine kind of bumps, but nothing like the methamphetamine would cause in the past. So more depression, maybe sometimes isolation. We have seen some recent studies that are showing increased rates of Parkinson's disease later in life. Parkinson's disease also has an impact on dopamine levels and changes kind of how your movement, like body movement, muscles can work. And we're seeing more and more Parkinson's disease later in life for people that have had regular use of methamphetamine throughout their life. We talked a little bit about some of the memory deficits, especially with like verbal learning. So being able to hear and listen, retain, and like apply that memory. Social cognition, so recognizing when how to act appropriately in different like social situations, kind of like reading the room, recognizing different social cues. We do see that there's pretty much not a lot of impact to general language skills or development, and the visual spatial abilities. And then we see a lot of executive dysfunction. And that's part of, like we said, prioritizing work, starting and finishing tasks, getting distracted really easily. That impulsivity is really impacted. Behaving maybe inappropriately in different social situations, which might be partially related to not being able to read social cues, and then also maybe partially because of that impulsivity and difficulty kind of self-regulating behaviors. Difficulty with setting goals, kind of a loss of drive, and then sometimes repetitive behaviors or perseverating on different topics when it's not maybe a healthy thing to perseverate on, or when it's past the point of being helpful to the person. And then we see a lot higher rates of depression, anxiety, suicidal behavior, psychosis, and other sometimes symptoms of mental health issues with ongoing methamphetamine use. And then we also see a lot of difficulties with sleep, long-term and short-term. So acute methamphetamine use obviously impacts people's sleep, but ongoing chronic use really has a long-term effect on people being able to have a regular circadian rhythm and release the right hormones and neurotransmitters to be able to sleep and recognize when they need to sleep. And that is something that we also try to address kind of over time, but we see a lot of that. So one of the things we see a lot, both with acute intoxication of methamphetamine and the chronic ongoing methamphetamine use, is psychosis. So it is sometimes difficult to tell if psychosis is like a organic or more underlying mental health issue, such as like schizophrenia or schizoaffective disorder, or if it is primarily like a substance or methamphetamine induced psychosis. So with methamphetamine use, generally psychosis presents more as like hallucinations. They're not always permanent, right? Sometimes it's just during the time that someone is intoxicated, or up to 7 to 14 days after. Those hallucinations can be visual, so seeing things, tactile. A lot of times people feel like bugs on them or things on their skin, which sometimes is part of like picking at things and messing with their skin and feeling like something is kind of agitating their skin. Auditory hallucinations are hearing things that other people aren't hearing, and that can be a wide array of things. Sometimes it's sounds, sometimes it's people talking to them, sometimes it's someone they recognize talking to them, sometimes it's, you know, a stranger's voice, sometimes it's just kind of background noise, sometimes they can really hear what's being said. So it's different for each person. So the methamphetamine use often presents as either hallucinations, such as those, or delusions. Delusions meaning kind of connecting dots that aren't really there and feeling like maybe people are following you or someone's out to get you, or sometimes delusions can be, I am a much more important person than I actually am, and I firmly believe that I am sent for some specific purpose. And then there can also be like a lot of paranoia, especially sometimes around like law enforcement and getting arrested or sent to jail. And then the delusional parasitosis is like feeling like you have bugs in your body or under your skin when there are not. So a lot of the ways that we do try to differentiate, especially in mental health, is this maybe a methamphetamine-induced psychosis, or is it more of an organic psychosis, mental health issue? With like schizophrenia, for example, a lot of times people experience similar things. They have hallucinations, they have delusions, sometimes paranoia. But in schizophrenia, we also see what we call negative symptoms. So those are things that are kind of taken away instead of positive symptoms, which would be like added to. So positive symptoms like hallucinations, something somebody doesn't have outside of that. So it's an added kind of symptom, positive. Hallucinations, paranoia, delusions, positive symptoms. Negative symptoms are isolation, a lot of time, really kind of isolative behavior, not talking very much to anybody, not connecting with other people, lack of interest in things, so very kind of withdrawn and isolated and just not interested in engaging in things. A lot of times we see with schizophrenia more of a blunted affect, meaning their like facial responses are not as bright or as responsive as you would expect, and then more slow movements. Another part of kind of figuring out, you know, where is the psychosis coming from is when did it start? Was this, you know, did you have this just after you were using methamphetamine and that's when it started, or was this kind of developing over a couple years? How long have you been experiencing the symptoms? This is part of how we kind of try to tease out where is this coming from and what is causing it. There is similar treatment, which we're going to talk a little bit about, for like psychosis symptoms, regardless of kind of where it's coming from. But it does make a difference also as far as like what kind of interventions we want to do long term, and what's going to help the person be more successful in working towards their goals, if we kind of have a better idea what's contributing to their symptoms. We do know that people who use methamphetamine are at a higher risk of experiencing psychosis than just kind of the general population. People who use recreationally are about 2 to 3 times more likely to experience psychosis. And those who use regularly are up to 11 times more likely to experience psychosis. We know the higher amount of use, the more frequently and for longer periods of time, kind of increasingly corresponds to higher risk of psychosis. And that psychosis can last just kind of for the duration of use, so around 12 hours up to indefinitely, because for some people it just doesn't really go away. A lot of times if people are successful at getting into recovery and stopping methamphetamine use, it will substantially reduce some of those symptoms. Sometimes they'll even go away, but it can still pop up sometimes if they return to use, or sometimes they might have more of those psychosis symptoms when they're going through a very stressful time. So it can kind of come up almost out of nowhere, seemingly, when they haven't had it for a while and aren't actively using anymore. But our brains respond to stress in different ways, right? And so sometimes that added stress can result in having more of those psychosis symptoms again. This is just kind of a nice little Venn diagram that was created to kind of explain the overlap between kind of all the different presentations, but psychosis symptoms can be very similar, right? So those positive and negative symptoms can exist for all three, but there are kind of subtle differences with each different I guess, experience that kind of help us know, is this an acute methamphetamine-induced psychosis? Is this chronic methamphetamine-related psychosis? Is this a schizophrenia? And then how do we kind of treat those to help the person regain functioning as much as possible? And I think you guys end up getting these slides too, so you can go over this some more if you want to. But it does just help to kind of know they are very different things. They can be, but there is a lot of overlap. So it makes sense that sometimes people end up with a diagnosis of schizophrenia sometimes, even if they may not have psychosis all the time, but it might be just fluctuating psychosis that is really kind of a result of ongoing methamphetamine use. We also know that people who use methamphetamine have a higher risk for developing or having depression. People that use methamphetamine and also have depression or depressive symptoms usually have a poorer prognosis, meaning more difficulty recovering from either or both conditions. And we also see that sometimes people with depression symptoms who use methamphetamine use more frequently. There's multiple theories on why this is, but essentially it's kind of a form of self-medication to try to help manage that depression that is there and kind of pervasive outside of the methamphetamine use. And again, if that's where you're getting your dopamine from and you really don't feel a lot of dopamine from other different activities, then sometimes that's how people tend to manage that. We also see an increased use or increased risk of suicide with methamphetamine use, actually even higher than with other substances. So, and we also see generally a higher risk of suicide with those who inject methamphetamine versus those who don't. So there's multiple things that kind of factor into that. And this is not to say that if you use methamphetamine, you are going to attempt suicide. Like, there's not a direct correlation, but we do know there is just a higher risk. And again, multifactorial, right? So possibly related to increasing impulsivity, that depression that we talked about, difficulty with managing anxiety and having that fight or flight response, sometimes feeling paranoid or like people are out to get you, or just kind of hopeless and overwhelmed can all contribute to that feeling. And then if your kind of inhibitions are reduced and impulsivity is increased, you may have make a suicide attempt or self-injury, harm yourself, without being able to necessarily think through all those consequences in the moment. So we know that people who have kind of a corresponding diagnosis of bipolar and use methamphetamine have the highest risk for suicide, and then followed by those with depression, schizophrenia, or other anxiety disorders, so PTSD, panic disorder, those type of things. Some of the studies that they've done have shown that the highest risk for suicide attempts are around within 1 year after being diagnosed with a methamphetamine use disorder. So at that point, to be able to have that diagnosis, that means the methamphetamine use is negatively impacting different areas of life. So school life, relationships, work, home life. Generally those different elements and having the negative impact is what kind of elevates just kind of recreational use. to a use disorder. And then some of the other studies showed that even sometimes 1 in 3 people who have used methamphetamine report a history of suicide attempts. So a fairly high amount. So we just want to kind of keep that in mind, that that is a substantial risk for people who are using methamphetamine, and make sure that we're kind of trying to either mitigate that risk or address the risk and at least be aware of it, and help in keeping people safe. Methamphetamine use in ADHD. So there's a whole lot of information out there about kind of both separately. There is new studies and research being done to try to understand better the interplay between the two. But there's a lot we don't know. So we do know that ADHD, generally combined type, which means like inattentive and hyperactive. So that would be combined type. So ADHD, the combined type, or just hyperactive type, tends to be more common in people who use methamphetamine. And we see a lot more kind of disability related to the ADHD with people who use methamphetamine use, and higher risk of unemployment, higher problems with those cognitive symptoms that negatively impact functioning, like planning and prioritizing work, starting and finishing work, organization, stuff like that. We know in the general population, at least here in the US, about 6 to 10% of children are diagnosed with ADHD. So generally it's seen more commonly in children. A lot of times children outgrow it by the time they're adults. So the general population, ADHD is diagnosed around 2.5% in the general adult population. And then we see for people that have substance use disorders, so they haven't really teased it out as far as specifically just methamphetamine use disorders, but substance use disorders in generally, there is a lot higher percentage of people who are diagnosed with or meet the criteria for ADHD, like around 20%. So there is some kind of correlation there, but still lots of research to be done to see kind of, you know, causative factors, what's contributing to that, and what's maybe resulting in that difference compared to general population of people. We know people with ADHD are 2 to 3 times more likely to develop a substance use disorder than those without ADHD. They have done some pretty substantial studies on this and have shown that actually earlier treatment for children with ADHD, like before they're 9 years old, so earlier treatment with stimulants, which like prescribed stimulants, is the therapy that is most recommended. Earlier treatment of a longer duration actually shows no increased risk later in like young adulthood of illicit stimulant use, illicit methamphetamine use, or other illicit stimulant use. And so, you know, that's at least reassuring to know that treating kids that have ADHD with the appropriate treatment interventions doesn't increase their risk later in life of having substance use disorders. But they do see higher risk of those substance use disorders later in life for kids or adolescents, especially who misuse prescription medications, i.e. they are not prescribed to them and they're taking them. So lots more research, I think, to be done on that. But we also know that, well, we know and we are learning, right, that as we're seeing more adults and methamphetamine use is becoming a huger and huger problem kind of across the globe, it turns out that it actually is a lot better for people to have the ADHD treated and the substance use disorder. And that is a combination of therapy and medication often that helps stabilize kind of both. And it's very hard to stabilize one without working on the other. So there's recommendations now that for people with substance use disorders, methamphetamine use disorders, and ADHD, the ADHD needs to be addressed, especially as adults also, and not just kind of pushed to the side. And a lot of times that means that they need or are prescribed medications That can include like the extended release stimulants. And the reason we really try to use the extended release is because it has kind of a longer coverage and there's a lot less abuse potential because it's not having that like dopamine spike and then drop. It's kind of providing the more consistent coverage to help with that cognitive functioning, executive functioning. And then there's also some non-stimulant medications that are very helpful. So like 10x is one, Qelbree, Strattera. So there's different options for people that can be very, very helpful. It is super important, I think, kind of across the board to make sure we are engaging people in treatment for mental health symptoms while they're still using methamphetamine and even when they've stopped or are using less. It's really hard to get ahead of some of the symptoms of the methamphetamine use without kind of engaging in treatment, and we can help with a lot of that stuff. So trying to figure out how long those symptoms last, like, you know, how pervasive are they, and targeting those to reduce the symptoms so that there's less kind of the self-medication and less having to try to manage it with what people kind of know how to manage by and what they have access to is something that the mental health care system is working towards. And then working on like how to reduce some of the triggers for ongoing methamphetamine use, working on those underlying or co-occurring issues, overall supporting functioning with different resources, sometimes housing, employment, building psychosocial skills, communication skills, healthy nutrition, kind of the general health stuff. A lot of times we use like antipsychotic medications. Sometimes we can use them just as needed instead of like every day, or sometimes they work better every day. We even have like long-acting injection medications that we can use that help keep those other kind of psychosis symptoms and mood kind of stabilizing symptoms at a more manageable level. So we kind of talked about this briefly, but also psychotherapy is important. So learning how to think about things and experience things, to not perseverate on them, to address some of those maybe thought distortions that people can have. So there's different kinds of psychotherapy, different things that might be a better fit for different people. And then we want to address like sleep problems, the depression, anxiety, suicidal thoughts. We really want to try to keep working on those, whether the methamphetamine use is ongoing or not, because a lot of times we can make a lot more progress if those other areas are addressed as well. Risk management, you know, suicide risk, medical, physical health risks. We're going to talk about that more in the next couple weeks and those different training options. Maintaining cognitive health and creating healthy cognitive processes, and just supporting the person, kind of meeting the person where they're at, right? What do you want to work on? How can we help? And just start there, because I mean, anything that's progress is progress, right? It is really important to not withhold treatment, like mental health treatment, if someone continues to use methamphetamine. I mean, generally it doesn't help, right? But it's helping the person with something. That's why they're continuing to use. So working on ways to address those underlying symptoms and what else is going on with them and helping them work towards their goals makes a huge difference. And then I'll just kind of add, for the sake of adding, it is important to make sure everybody has naloxone. So it's important to have that naloxone available to help with overdose, especially the unintentional overdose from opioids, the fentanyl, to help keep working again on that harm reduction and working through all the different symptoms and experiences the person is having. And yes, I think that is all I've got for you guys. And any questions, we'll open it up for all of you.
Yeah, thanks, Kayla. So yeah, we have some time here for some questions or comments. So if anyone wants to go ahead and unmute or type that into the chat, this is the time to do it. So thanks, Kayla, for going through all that. Very, very practical and helpful. Here's a question in the chat. Is there a risk for addiction for using ADHD medications? So Kayla, yeah, tell us a little bit about, just your approach to treating ADHD in someone with a methamphetamine use disorder.
So if they have, sorry, I don't have the chat open. So if someone has like a methamphetamine use disorder and also has ADHD, I really try to work with them and kind of find out like, how often are you using methamphetamine? What do you feel like it's helping you with? What doesn't it help with? Kind of trying to find what is supporting or causing the patient to continue using, and then see if that's something we can address with medications. Generally, I would say, well, kind of like we discussed, we can prescribe stimulants for ADHD. If someone's actively using methamphetamine, though, we're going to want to be really careful about that, to not be giving them a bunch of excess stimulants, but also really focusing on using those longer acting stimulants that are going to provide that kind of full day coverage and help with hopefully establishing a schedule, being able to sleep. But we also have medications that aren't stimulants that a lot of times can help with like sometimes the physical restlessness and being able to kind of be more still and feel less anxious, help with kind of slowing down the brain when you have that kind of racing thoughts and easily distractible and all that stuff. So it really is kind of situation dependent, individual patient dependent. A lot of times, if someone is actively using meth, they probably need to be seeing someone who is kind of a specialist in addictions and substance use disorder and ADHD. Like that's not generally something like primary care is going to manage or something. But it's not necessarily like a no-go. It's just a matter of trying to address what's going on with that patient and help them be as functional as possible, and also like manage some of the risks associated with what's kind of going on in their life and how they're able to manage different things. Does that hopefully kind of answer your question?
Yeah, Kayla, I think that's exactly right. And I will say also, so to be very specific, there is a small risk that people can use stimulant prescriptions and get addicted to it and that sort of thing. But honestly, I have just not seen that happen when I have treated people with ADHD who also have a meth use disorder. Because we do want to support their ADHD symptoms, because that's going to help them, engage the most with their treatment for their SUD, but also in life. And so it is worth thinking about. And honestly, I've had more people just tell me they've stopped their stimulant prescription in this context because they weren't feeling it and it wasn't really doing what they thought it would do, et cetera. So although there is a small risk, I haven't found this to actually play out in any meaningful way clinically. So great question, and thanks, Kayla, for the response. Other questions that you can chat in, or maybe just unmute and walk us through. Kayla, while we're waiting, I'm kind of curious, what is like the main mental health set of symptoms you're seeing in your patients with a meth use disorder? You went through that. It can really affect depression and psychosis and ADHD and all these things. What is there anything that's coming up more often than not in your practice?
I would say kind of a combination of the psychosis and depression, honestly, especially for the kind of longer term, more consistent use. We see a lot of more almost permanent psychosis with kind of some delusions and stuff. And really a lot of struggling with depression once people are wanting to try to reduce their methamphetamine use or try to cut back and realize that they really struggle with the depression that's kind of left once they don't have that they're using every day. So working with them to kind of find other medications that are helping regulate and kind of stabilize some of those neurotransmitters. It's a bit of a journey because a lot of the meds they don't work immediately. Like they take 4 to 6 weeks to kind of know how the patient is doing with them and if they're helping, which is very different than using meth and, you know, it kind of having an effect that fast. So a lot of working on kind of depression and some of the psychosis that can kind of wax and wane and fluctuate for a lot of people.
Yeah. On the med side for these depressive symptoms, is there any particular meds you're finding more helpful than not?
It really depends on the patient because you have to also kind of make sure you're double checking that there's not an underlying bipolar disorder or other things. Some of it, again, is pretty hard to tease out if especially if they started using methamphetamine, you know, in their adolescent years. And sometimes you try medication and it doesn't work. But a lot of times antidepressants, like some of the SNRIs, like Effexor or Pristiq, sometimes Trintellix, some of the more kind of activating antidepressants, Wellbutrin, a lot of times can be helpful. But it really kind of depends on the patient and what their kind of most presenting problematic symptoms are of the depression. And it also depends on if they're able to take medications pretty consistently or not, because all the meds work a little bit differently. And so sometimes there's just a better fit for some people because of how they take their medications.
We have time for one more question, but not a lot. So do your best to answer this as quick as possible. Are there medication-assisted treatments, you know, similar to methadone or buprenorphine for OUD for meth? Anything like that?
So no, not really. The treatment of choice really for methamphetamine use disorder is contingency management. So that's kind of a psychotherapy interventional treatment. It's not a medication. But we don't do like a replacement therapy for methamphetamine use disorder, but we do, again, like addressing some of the underlying issues, like treating the ADHD, treating depression, treating maybe some of the psychosis symptoms, treating those with medications a lot of times helps stabilize other things for the patient, for the person in their life. And so then they're not having as much chaos. They're not feeling like they need to use methamphetamine as often or at all. And then definitely like addressing any kind of OUD and having treatment for that, methadone or buprenorphine, also goes a long ways if there's co-occurring use to help stabilize things and seems to make a huge difference, I think.
Yeah. All right. Thanks. All right, we are at 12:55 here, so I'm going to turn it over to Leilani to kind of talk through the upcoming schedule and resources and all that sort of stuff. So thank you very much, Kayla, for this presentation and discussion. Super helpful. Really appreciate all your work and effort today.